All right, another set of practice questions. The first one, static station, multitrauma, high-speed motor vehicle accident, query, TBI, chest x-ray, pelvic x-ray, CT, thoracolumbar spine. The question is to describe abnormalities. The person's not sure about their chest x-ray findings, but look for pneumothoraces that might be very small, a hemothorax, any rib fractures, any clavicular or humeral fractures or humeral dislocations. Comminuted burst L1 fracture with central cord narrowing. I assume that they mean spinal canal narrowing on CT. What is the syndrome? And the answer that's been provided is cord equina or conus medullaris. That could happen, either could happen at the level of L1 fracture. What is the surgical management and why is it required? So the patient will require decompression surgery at L1. They can be decompressed anteriorly with a corpectomy or posteriorly with a laminectomy. That is a very specific decision to be made by the spinal surgeon, not the rehab physician. And then they will need to be stabilized somehow, and I will be thinking that they'll have a posterior fusion at least between T12 and L2. And why is it required? It's to relieve pressure off the spinal cord, to stabilize the spine, and hopefully promote recovery of the spinal cord. How would you determine whether the patient is a candidate for rehab? So they will highly be a candidate for rehab. It doesn't specify whether it's general rehab, brain injury rehab, or general rehab. The most important factor that would determine whether they come to rehab or not is whether they're able to participate in rehab. So their cognition has to be adequate enough so that they can actually participate and benefit from the rehab program. If a patient has a TBI that is extremely severe and they are not alert for most of the day and cannot follow instructions, they would probably not be eligible for any rehab until they can participate. They also need to be medically stable, because the question does say, how would you determine whether a patient is candidate for rehab? So they also need to be medically stable enough for a subacute ward. Ideally, all drains are removed. They can have an indwelling catheter in situ. And hopefully they don't have a tracheostomy. If they do have a tracheostomy, the team will need to be trained and accredited to manage tracheostomy. I'm just editing here and realized that this question may be asking how you would select which rehab program the patient goes to, whether it be spinal cord injury, brain injury, or general rehab. It really does depend on what their predominant goals will be. So brain injury rehab would really be for a patient who has predominant cognitive and behavioral goals to address, and they might be someone who might be at risk of absconding and will need a locked ward. A patient would be eligible or more appropriate for spinal cord injury rehab if most of their rehab goals are related to bladder and bowel dysfunction. If the patient's goals are predominantly related to mobility and they don't have a lot of cognitive, behavioral, bladder or bowel function goals, then general rehab might be more suitable. Okay, second question. It's a live station. It's a spinal cord injury communication station. You're shown a patient's Asian neuro sheet outside the room. It is potentially C4-5 AISC and they're 1 month post-injury. So I'm assuming that the patient is C4. So in the past, spinal cord injury was previously expressed like this. So you would write 2 levels, so the intact level and the affected level. But nowadays we just write C4 AISC. Can you explain to me my spinal cord injury classification? So if they are a C4 AISC, I would say C4 and above, you have intact nerve function, and that's from the top of the shoulders upwards, you have normal nerve function. C5 and below, so below the shoulders, you have nerve function that is somehow affected. And what may be impaired would be muscle strength and sensation or feeling. at the level of C5 and below. AISC, so the AIS classification represents the severity of the injury. There are 5 grades of AIS severity, so that's from A to E. A represents the most severe form of spinal cord injury and usually carries the poorest prognosis. Less than 10% of patients progress from AIS-A to a better neurological grade. AIS-E refer to patients who've had a spinal cord injury already but have had significant recovery, so much so that on the INSCI examination there is no abnormalities found. So the patient is AIS-C, so they represent a moderate spinal cord injury. And in the first year, between 50 to 80% of patients progress or improve to AIS-D, meaning that they usually can walk. C for AIS-C, it indicates that from C5 and below, less than half the muscles have anti-gravity power. And AIS-D means that more than 50% of the muscles, C5 and below, have anti-gravity power or more. And most of the time, patients with AIS-D can walk again. So that's between 50 to 80% of patients. So your chance is essentially between 50 to 80% in the first year of returning to walking. Next question. I've heard about stem cell research, thinking of going to China. What do you think? So what I would say is, stem cell research is certainly a very exciting field, and it is currently being studied in spinal cord injury. However, at this stage, there's not enough evidence to indicate that it provides more benefit over risk. Stem cells are immature cells. When administered, can transform into any type of cell, in which case there is an increased risk of these immature cells becoming cancer. In spinal cord injury, stem cell therapy hasn't demonstrated significant change in functional outcome. Stem cell therapy has shown some benefits in patients with limited lifespan, such as hematological malignancies. In this group of patients, they may increase lifespan by a few months, and these patients may choose to have stem cell therapy for personal reasons. In patients with spinal cord injury who have normal lifespan, we're unable to recommend that you have stem cell therapy in the event that these stem cells turn into cancer and shorten your lifespan. So right now, the recommendation is still for rehab. I'm not going to do question 3 because, as I was saying to the trainees that we have here today, upper limb amputees are actually rarer than spinal cord injury, and I have not seen enough after my post-fellowship to answer this question. So I'll let you talk to the prosthetist about it. Okay. Question 4. It's a live station, hypoxic brain injury communication station. The patient had a cardiac arrest. The downtime is about 30 minutes. They are now agitated and the wife has questions. So why is he agitated? Essentially, the patient has had a brain injury due to lack of oxygen supply. There's likely a lot of swelling in the brain and it is trying to heal itself. The lack of oxygen supply can cause a global injury to the brain and therefore causing the patient to be disoriented. They are delirious, their level of consciousness is affected. So this form of brain injury could lead to agitation, confusion, or even aggression. He also had a cardiac arrest, in which case CPR would have been done. So he may have some pain in the chest from bruising or even rib fractures. The patient may have other noxious stimuli which is causing distress, but he's unable to communicate it. For example, constipation or any abdominal pain or discomfort in his joints, things as such. Okay, next question. How would you manage his agitation? So we found the answers in the red book. So mine is in the second edition and the answers are they're from page 78 all the way to page 82. So given that there's 4 pages of information on here, I will let you go ahead and read up in your own red book. I do feel that the way this question is phrased over here, given that it's only one part of a question, it potentially has not been written down here properly. My best guess would be that they might have asked for, give us 10 non-pharmacological ways of managing agitation, rather than just how would you manage this agitation, because it's just a portion of the question. It's too broad. That's my opinion. Okay, moving on to the next question. Static TBI station, high-speed motor vehicle accident, still in PTA after 2 weeks, MRI brain, and you've been asked to describe the findings. There's subarachnoid hemorrhage, left occipital and bifrontal contusions, left frontal parietal subdural hemorrhage, and effacement of ventricles, and there's an IVD in situ. Westmead sheet indicates that there are fluctuating scores and there's no 12 out of 12 yet. Neuropsych has said that patient is out of PTA and doesn't need further testing. What features on the Westmead test indicates that the patient is still in PTA? So the inability to have continuous memory, and typically if the patient does not score 3 consecutive 12 out of 12s, it indicates that the patient is still in PTA. However, it is a gross test, and as I was saying to the team here, sometimes there are some patients who just are unable to participate in the PTA and score 12 out of 12. These might be patients with pre-morbid cognitive impairment, or intellectual disability or mental health disorders, limiting their ability to actually do the PTA testing. And it's highly appropriate to have neuropsychology come in to do a more thorough assessment and clear them from PTA. That will be my answer. Again, it's a static station, so I might be wrong. Perhaps go and check with your brain injury physician and see what they think. Explain the neuropsych report. I assume there'll be a report. What features of these case indicates poor prognosis? Again, this is a really hard question without the report, but at least if you have something in writing, it means that you can go through the findings. And I mean, for me, the very obvious answer is that whatever is below average is going to be an indication of poor prognosis, but I feel like that answer that I've just given you is too obvious, so it will depend on the question. The next one, question 6, is a live station, motor neuron disease, and it's a communication station. It's a young male with motor neuron disease. They're drooling, and I'm not sure what this is. What else? And the question is, I'm having difficulty with managing saliva. What can be done? So you start with least invasive strategies first. We can try nebulized normal saline, followed by amitriptyline, glycopyrrolate, and hyoscine, as well as suction. Of course, there's some evidence that salivary gland or parotid gland Botox can be done in order to decrease saliva production. And also, they can potentially be referred for salivary gland duct ligation. In terms of some other medicines that have been indicated, so scopolamine, that's one, benztropine as well, but in clinical practice I haven't used these two, but it doesn't mean that you can't. Okay, so next question is, I'm thinking of joining a gym program. Do you think it is a good idea? I do think it is a good idea. Ideally, go with a therapist, a physio, or an exercise physiologist who is familiar with motor neuron disease. My advice is to not exercise to the point of muscle fatigue, and participate in the maintenance program to maintain strength as well as joint range of motion. I know my condition is progressive. What should I be considering in terms of planning for the future? So this is about advanced care directives and will and planning ahead. So advanced care directives you can indicate a substitute decision maker for accommodation, health, and finances in the event that the patient with MND loses capacity to make these decisions independently, and this certainly can occur given that there's frontotemporal dementia that is associated with MND. So that's important to have a look at. Also, consider writing your will so that people know how to distribute your property and assets once you pass away. Definitely stay in touch with your MND team, because as your condition progresses, you're going to need ongoing input and modification of the equipment, and medications you might need. There are also other resources with MND Australia, so check out their website. Also consider your goals that you like to achieve before your condition deteriorates so much that you're unable to undertake them. Okay, that's all for today. Thank you very much.